Hello, everybody. My name is Carsten Hermes. I'm a German intensive care nurse, and I'm very happy that it is allowed to give you a brief lecture on the World Delirium Day. My topic today is the delirium management as a modern approach with the A to F bundle. Please notice that I have a conflict of interest so far that I have received fees and contributions for speakings and consultings activities from various companies in the last 3 years. Like I mentioned before, my name is Carsten Hermes. I'm a special nurse in Anesthesia and Intensive Care. I'm also an Intensive Care Instructor. I have a master degree as an advanced nurse practitioner and also a bachelor degree in business administration, and I'm the co-founder of the German Delirium and Early Mobilization Network. My practical experience are from 1995 to 2080 in various hospitals, district, acute, general, universal, and private hospitals as an intensive care nurse and a head nurse for several departments. Now I'm self-employed and an independent consult, and my main themes and topics are the implementation of delirium and early mobility concepts in different hospitals, also team building and change management. Currently, I'm the speaker of the German division of the German Society of Medical Intensive Care and Emergency Medicine, DGEN. So what is the aim goal for all our patients in the intensive care treatment and care? And we have sentences in the German S3 guideline that summarize that the patient should be awake and calm and cooperative. Of course, without pain, delirium-free, and without any fear. And I ask you, is this the reality in your early shift, in the night shift, in the late shift? Of course not, because this is a goal, and we have to clarify that we need goals to reach them. And this is a description of the future, what we want to reach and our aim. And then we have to see how the present is, and we have to compare the present with the goal. And this gap shows us what we have to do. And for those actions, we need a plan. And this plan is not how it should improve in the next hour. Sometimes it's possible, but sometimes we have this traditional reflex. When the patient is not really calm enough, we just want to administer something and bring the patient to a calmer, relaxed level. And it's not random that we have 24 hours later this Christmas tree of medicine, because usually it starts with one drug, and it's hardly ever to stop this process. One drug is replaced usually by another one, and when the patient is not calm enough, we bring the next one to the patient, and we are sometimes not really thinking about the aimed goal that I mentioned before. And this is what we want to change. We want to change this, and we want to do something different. We want to bring the patient to another point of view, and we want to bring our teams to another point of view, because it's not really, it's not really the daily work and the daily structure that patients are not really straight in the room and sitting to the front of the window and looking outside, especially when they have a tube. Then it is something that could afraid us, our colleagues, and also the physicians in the medical round. So it is not normal that a patient does not stand straight in the room and is not looking at the ceiling. And this is what we really want to change. And we have to think about different things behind this. Of course, we want our esteem, but also in the modern days, it's completely normal that we want to connect the patients with the family. And for those situations, we need Wi-Fi, batteries, computers, and everything else. And it doesn't matter if the patient is intubated or not. So let's have a brief look into the A to F bundle. And I only want to mention each of these letters in a short way. All letters have behind the concept of the early goal-directed therapy. And for those, we need setting targets. We need the targets, like I have said in the beginning of the talk, of the calm, relaxed, and awake patient. And then we need tools to measure the situation in the present and to cover how we can bring the patient from the present to the future end goal. And this is what we call a target-driven treatment. And this is also possible in a non-pharmacological or in a pharmacological way. The best thing for our nurse colleagues is that the non-pharmacological approach is also a treatment, a therapeutic approach, and preventive approach. This is much more than the pharmacological treatment always is able to reach. But assess first and then administer medicine, and recognize that the ICU therapy is painful, and we have an underestimated level of pain in most of our ICU patients. For those, we need Wallet scores to measure the pain. Also, we need Wallet scores to measure the agitation and delirium. And when we try to treat pain, we have several things to use. It's said in the guidelines that we have to use first IV opioids, and we are able to combine this with the anaconda system, volatile sedation. It's a common thing in Germany. And this can also lower the need of IV opioids. But sometimes it's necessary to avoid both of them and to bring some paracetamol to the patient, because each pain reliever has a different way of working in the body of the patient. And more important than the pharmacological way is the non-pharmacological treatment. You can use the relaxation or distraction techniques and bring the patient to another level of activity. Also, to include the family is not a bad idea at this point. Or use music therapy or therapy animals. And it's clear that the patient have to be briefed by himself, otherwise we are not able to extubate him. And for those, it's also a beneficial situation that the patient is not too deep sedated. So we need both a spontaneous awakened trials or a continuous spontaneous breathing during the ICU. And this is all important because it could shorten the ventilation time also after the target temperature management, what we call it also sometimes cooling. We have a shorter wake up, and for those situations we have decreased sedation needs. We have a faster extubate ICU patient, and this reduces the length of stay on the ICU and also length of stay in the hospital. And this is the point where the budget holder and the manager become your friend, because when you reduce the length of stay, you have a better economic outcome. But for the patient, it's more relevant that we prevent muscle atrophy and avoid paralysis of breathing muscles when the patient is most of the day breathing by himself. And also we have a better hemodynamic situation. But what means that the patient is able to breathe himself? So we need a target area for our sedation, and the new standard should be the no sedation standard. The meaning of no sedation, in my opinion, is not that we don't administer any medicine. It's more the meaning of the patient is not in a sedated level. And for those, we can use the Richmond agitation and sedation scale to measure the level of consciousness and the level of sedation. And we can also use the RAS when the patient have no medicine running and is not administer any sedated medicine, because the RAS is also a good tool to describe the situation, the current situation of the patient. It's more a measurement of the consciousness than of the sedated state. And it's necessary to bring the patient to a level of 0 or -1. But also for those treatment protocols, we need the knowledge about the different medicines, and we need a new choice of medicines. So the first point is we should avoid that we use sedation regularly for every patient. So we have to think which patient needs medicine and which patient is fine without. But clear is that we have to avoid also the using of benzodiazepine. There are only a couple of indications like epileptic state or an withdrawal with alcohol where it's good to use benzos. And the medication must be easily and quickly controllable like a helicopter, not like an old plane. So you need a combination of different medicine on your ICU. And for all we need adaptable to the requirements, what means that the patient should always be in a level of RUS of 0 to -2 or -1, especially when there are no real reasons to bring him to a deeper level of sedation. And sometimes when it's necessary, it's only necessary for a couple of hours, for example, when we bring him to a prone position. It's also able or practical to have some of the patients awake in the prone position. The problem with the benzodiazepine is that we have direct dose-response relationship, and this is also associated with the delirium. So it's only a question about time when the patient is delirious when we are using benzodiazepine. And to say it clear, and again, the modern sedation control does not mean that we will not administer anything. Sometimes we need a deep sedation situation when we use the suction, the prone position, or any other things when we are work with the patient, for example, when we are cover the wounds and so on. And sometimes it's also necessary to cap the agitation peaks when the patient is a little bit afraid, but we have to really be aware and avoid the situation that we administer so much that we bring the patient to the blue, to the deep level. And when we fail to detect delirium, it's often because we are not using the right tools. And it's also that we think we see every patient from the door side that he is delirious, but only 5% of the patients are hyperactive and agitated. Most of the patients have a mixed type, and 30% of all patients have a hypoactive delirium. Calm patients that are laying in the bed say yes and no to everything, and those patients are really often undetected with the worst prognosis. But what does it mean? The hyperactive delirium, I think it's clear with the restless situation and removing all the cables and tubes. But the hypoactive patients sometimes is our best friend because he is not really worky. He is laying in the bed. And it's sometimes more that he is asleep and doesn't really make a lot of burden or workload. But those patients are really underestimated in the outcome, and they go down, and they are the patients who have a higher mortality. But what is delirium? To remember, we need the DSM-5 criteria. In Germany, we have the additional ABCDEF that is necessary to get a reimbursement from the health injury. We have to write down that the patient also have a sleep-wake cycle disturbance and the psychomotor disturbance. But to diagnose delirium, it's only necessary to have the DSM-5 criteria on the screen. And this means that we have a disturbance in attention in a way of a reduced ability to direct, focus, sustain, and shift attention in combination with the problem in the awareness, what means reduced orientation to the environment. It develops in a short period of time and fluctuate over the course in severity during the course of the day. And sometimes we have additional disturbance and we have additionally hallucinations or disorientated situations, but not every hallucination is associated with the delirium. So what does it mean for the patient when we treat every hallucination with medicine or haloperidol or other bad drugs? It means that sometimes we're doing the bad things, the wrong things. I want to give you a little view and idea of what I mean when I say that not every hallucination is worthy to treat. So please have a look on this picture. Have a look on the 4 black points in the middle of this picture and take a deep breath. Take a deep breath through your nose and through your mouth out. A breath inside your nose, and look at the 4 little black points on this picture. And please keep your eyes on the screen. It doesn't matter what happened now. And perhaps you had an hallucination. Some of you have seen nothing. The others have seen Jesus, and others only have seen a man with a bird. So it's clear that this was a little trick, but it's also clear that some of our medications are producing more hallucinations than other ones. But to point it out again, it's not necessary to treat a hallucination when the patient is without fear, agitation, or other symptoms. So to detect the delirium, we have different tools. We can use the CAM-ICU as a physical examination, a combination of different tests on one card, but this is a look in the present. It's only a situation when you interact with the patient. It is necessary that the patient is able to interact with you, and it's complex to do the CAM-ICU when the patient is in a level of RASS of -3 or deeper, and also it's tough to do the CAM-ICU when the patient have a RASS of +2 or higher, and it's not doable in a way when the patient is in a RASS level of +4. And sometimes when nurses are doing this and they want to hand over the patient to the physician, and the physician try to make the same test again, sometimes due the fluctuation situation, we have different results in the same shift, and then we have a discussion about who's on the right side. And we also have the intensive care delirium checklist, and this is a retrospectively view to the patient. It doesn't say anything about the future. And to have an objective monitor, we can use an EEG, for example. But the EEG is complex. In the EEG, it's possible to distinguish a delirious or no delirious situation, but to conduct a full EEG takes significant time, and you have artifacts and everything else, and the interpretation was difficult until we used the one-channel EEGs. Detection and monitoring of delirium and the acute encephalopathy is now possible at the bedside of the ICU patient. And the scores of those screens shows us, for example, here with the 5, and this is the raw data EEG that I'm able to show to you, that the patient is in a delirious state in the meaning of polymorphic delta waves, or he's scored by a 2 without any polymorphic delta waves. And all those separate measurements you see here on the screen came from the same patient. So we have a new possibility to bring the detection of delirium and acute encephalopathy to the next level. But the most important thing is the early mobility and exercise to avoid all these negative consequences of immobilization, what we call deconditionation. When the patient is only laying in the bed and is immobilized, we have a reduced hemodynamic responsiveness, we have an ICU-acquired weakness in some of the patients, and we have the problem of the fatigue and atrophy of the muscular, respiratory, skeletal, and pump system. So despite of the skin damage that also causes sometimes, it's a bad situation for the patient to lay the whole day in the bed. And we know this. And especially the physician and nurses have a different view to the patient. What are the possibilities for mobilization? And this is what we have also found out in a little working group from the German Delirium and Mobility Network, that different professionals scored mobilization capacities of patients differently. The same patient on the same unit in the same shift is estimated in a different way, and nurses and physicians estimate it significantly lower than the physical therapist. And this means that there is a high need of interprofessional educations where the physician, nurses, and physical therapists are trained and educated in the same room in the same time. And we need interprofessional medical rounds to bring the knowledge of all colleagues at the same time to the bedside. And we need accurate knowledge of mobilization also when the patient is sedated, intubated, and on the ventilator, because we have sometimes more possibilities than we assume or expect when we are not really familiar with the concept of mobilization, intubate, and ventilated patients. And also, it's important to include the family engagement and empowerment, because human care is much more than we are able to do alone on the ICU. We need a reliable inform of the patients and families. We are able to include them in the medical rounds, and also we are able to providing physical comfort, emotional support by the family. And this also means that we have to consider all the patient's culture beliefs into all our things we do. And one of the best things to change the view to this side and to begin the change management is to have open visiting hours on the ICU. And I know this is really tough in the COVID situation, but at any point where it is possible, it should be done. You should try to use open visiting hours from the close relatives of the patient. But what does all this have to do with us when we think about acute encephalopathy and delirium? You have to prevent everything, because every acute encephalopathy and delirium have an underlying physical cause. And when this cause is there and it appears with a delirium, it's really hard to treat. And the nursing perspective is to prevent everything. And when it is there, we have to monitor and we have to monitor the severity and also our treatments. So sometimes it's better to do less than more. So avoid a deep sedation, avoid special medication, and bring the patient to a next level of activity. Also avoid the immobility and use objective tools to detect and monitor acute encephalopathy and delirium. But the most important thing is, please try to avoid acute encephalopathy and delirium. We have to do everything in a preventive way, because when all those bad things appear, it's really hard to treat, and there is no medical treatment of delirium. There is just a symptom control possible. And especially for our elderly patients, we have to do this, because a young patient really needs a hard push to bring those young healthy people to delir or POCD or PTSD. But all geriatric and elderly patients only need a little touch, and they are eaten by the sharks here in the bottom. And I want to summarize with my conclusion. No matter how beautiful the strategy is you have, you should look at your results occasionally. This is what Winston Churchill have said in the past. So when you are not happy with your results, start with the change management and include everybody from your unit and make it as a real interprofessional approach with an objective monitor of everything you do. And at this point, I want to thank you for your interest and time. Say goodbye, stay healthy, and enjoy also the World Delirium Day with all those lectures in the next hours you find here in the internet. Bye-bye.